Okay, so hello, Ignacio. Really nice to see you again. We
Hi,
are
Julio. Nice to see you again.
yeah, perfect. We are just really glad to have you here. That's a new video section that we have from LACES. And today's talk, it's about the following statement: becoming a surgeon who thinks outside the box. How to stay within the classical surgical indications, have great results, and still generate innovations. That's a broad topic, but in the beginning, I just want to know about you. If you can give us a brief information about your biography. Where did you do your cardiothoracic training and who were the main mentors in your career?
Well, Julio, thank you very much. It's really a pleasure to be here. I really like this kind of interviews. It's a good moment to explain a bit of our history and trying to inspire others to learn more and practice and innovate. So I thank you for the opportunity. Well, my story, I am from Argentina. I am originally from Argentina and I live in Argentina. So Argentina has a very particular educational environment. I had the chance to go to the public school, and then after that, I went to the public university. So I studied medicine, and after I finished, in fact, during my career, I wanted to become an engineer in therapist engineering. So those guys that look into the genome and get to and find solutions for son and all that. So after I finished my med school, I was hired by a very important lab here in Argentina, and I started genetic therapy, working in rats to try to find a cure for Parkinson's. I find it really interesting, but the problem is that my character, my personality couldn't hold that, because I was kind of a bit anxious because I had to wait, I don't know, 4 years to have a result. So after 6 months, although I think that is the medicine of the future, I decided to quit and try to find a bit more adrenaline in my job. But I really didn't know, I knew nothing about cardiac surgery, to be honest. So I started looking at the different subspecialties of medicine. And I said, okay, surgery plus abdominal cavity, well, I don't like that. Okay, surgery plus the brain, too many tumors, I don't like that. So when I came to the heart, I said, okay, heart plus surgery seems really complex and really interesting. So I had the chance to talk to a friend of a friend of the mother of a friend of mine. So she had a close friend who was a surgeon, adult cardiac surgeon, and he invited me to go and have a short talk. And the guy started asking me, well, okay, do you like, I don't know, the heart or the great vessels? And I said, okay, the heart. I didn't know. Do you like adults? Do you like pediatric patients? Well, I think I prefer pediatric patients. Well, okay, but I really didn't know. And the guy contacted me with a pediatric surgeon, a pediatric cardiac surgeon, and he invited me to go to the OR. And when I saw the first surgery, I was amazed by that. And at that precise moment, I decided to become a pediatric cardiac surgeon. I had the chance to enter the residency at the hospital, Children's Hospital in Buenos Aires. And under Guillermo Kreuzer's guidance, and he was one of my main mentors. So I started very early because the pediatric cardiac surgery residency was a first level residency. So at my 25 years old, I was in my first year residency of pediatric cardiac surgery. So that was really a short way until I get to my training.
Okay, it sounds really good. It was like a brief description, actually. So my next question is following. We know that in the universe from adult cardiac surgery, we don't have a lot of flexibility with the treatments. we always need to base our therapies on guidelines. I think that in the pediatric universe, you have more flexibility probably to change, to address one disease in a different way. You have like more room to generate new approaches. Do you think that is also something that guided you to go to the pediatric way?
Absolutely. Absolutely, absolutely. Because from the very beginning, in fact, that surgeon, that adult cardiac surgeon that first talked to me, in fact, he told me that adult cardiac surgery was, of course, very complex, but the number of procedures were more limited as compared to the pediatric cardiac surgery. And I had a chance to witness that at my first operation. I don't exactly recall what it was, but I still have the feeling that was very complex, and the surgeon was trying to design the proper operation for the patient at the very moment that he was operating on. So I found it. I found that was amazing. That was really complex. And during my residency and my post-residency work, I realized, and that is what I probably love most of my field, is that there is no patient that is the same than another one. And there are no two tetralogies of Fallot that are the same. So you have to apply a large number of techniques, and you have to think exactly about the patient you have at that moment on the table to decide which treatment is the best for that one. So there is a lot of room for improvement and for innovation.
Okay, incredible. My next question is about the one disease that probably you are extremely involved. We know that there was a huge contribution from your side about this scimitar syndrome repair. I would like to ask you if you can comment how was the process between having a possible idea that could repair this syndrome until having like a good concept to do that?
Well, it was that was kind of a short story. There are different ways to innovate. I always say, in that particular case, that was very short in time, because I had that first case of a young adult patient with scimitar syndrome, undiagnosed scimitar syndrome, and as I got the images of the CT scan, I realized that the different approaches that have already been described for that disease would really not have good results on that patient. I was clearly aware of that because of what I already knew and about the literature. In fact, I read a lot of papers during those previous days. But the night before, I was looking for them, I don't know, my 10th time to the CT scan images, and suddenly the idea just simply came to me, and I saw it. I saw how could I reroute the right pulmonary venous return to the left atrium without causing distortion and using the pericardial sac. My inspiration was the sutureless technique for pulmonary vein stenosis. So it had a part of different operations. Of course, you never innovate from zero, from nothing. You step on previous innovations to build your own innovation. So I went the next morning, the day of the surgery, I went to the family and to the patient, and I told them, well, look, as I told you before, there are no really very good options from the viewpoint of the surgeries that have already, techniques that have already been described. Of course, we will try to stay to that. I don't want to innovate with you. I prefer to do what is established, but if I see that there is no other option, I have an idea. Would you be willing me to try that? And the family was completely supportive, and the patient. And I remember quite well that she told me, do what you think is the best for me. We trust you 100%. So the operation took 11 hours because we kind of invented it at the time of the operation. So that was really an important moment, and this support from the patient and the family was very important, very important. And the result was very good. The patient was discharged home 3 days later, and still we are about to publish a paper of 10 years after this operation. So it's important. But innovation doesn't happen usually that way. Innovation is, I always say, it's 1 minute of inspiration and 1 million minutes of perspiration. So suddenly you can have an idea, and it's just a minute. You have to be perseverant during years to get your idea to become real. So that is the usual way of innovation. There is no other way to innovate, to be persistent.
That's really good. That's an extremely good message. I have my final question. Actually, is two combined questions. Number one, how do you stimulate innovation inside your department for the young generation? And the number two would be, if you are involved in new projects, what can you tell us about other pathologies that you are trying to bring new concepts and new techniques?
Well, regarding inspiring other young surgeons to innovate, it's not always easy, because it depends a lot on each one. Here we are not, let's say, forced to do research. So there's some people that they really are interested in innovating, in doing research and all that. What you can provide people is with the environment. So if you teach every day that you are trying to think outside the box, but at the same time staying in the proper way to make the patient do well. So, but at the same time, define the previously defined concepts and trying to think outside the box. It's a very, very subtle thing. So, but if you provide that young surgeon that is starting with his or her career with a very rich environment, you will probably that person will probably end up taking that as the normal thing. And when that person, that doctor goes out of your system or goes to another hospital, probably that you have planted that seed. So that's the way I think that you can try to make them more innovative. So it's by leading by example. And regarding other projects, yes, I'm working hard now on a project that is related to semilunar valve reconstructions. We have developed a method and a device with which we can reconstruct a symmetric and oversized valve for those patients, especially pediatric patients at the moment, that need an aortic valve reconstruction. As you probably, well, you're aware of the Osaki method, but the Osaki method has been described for adult patients and doesn't take into consideration really the anatomy of the patients. Our patients usually have bicuspid valves and tetracuspid valves, so the method of measuring the intercommissural distance is not very appropriate. And also this method has been designed for the adult population, so it doesn't take into consideration growth of the patient. So we are working on that method and on the device that tries to make the procedure more reproducible and easy and fast for the surgeon. So we are currently working on that. The method and the project is called Avatar, due to aortic valve tri-leaflet autologous reconstruction, for that name, and we are working on that. And besides, we have other lines that are related to high-V procedures. For example, we have developed a method we think that pulmonary valve replacement in post-fallow patients that have a really dilated right ventricular outflow tract do not really have to undergo surgery, because you have the conventional methods of making the pulmonary percutaneous pulmonary valve replacement. But for those cases in which the right ventricular outflow tract is really severely dilated, you cannot put the valve inside. So what we design is kind of a plication. It's a geometrical plication that allows you to simply open the chest, do not get the patient on pump, reconstruct the right ventricular outflow tract, taking into consideration the precise measures of each area, each part, and reconstructing in order to make a landing zone for the percutaneous valve. So we are working on that, and also on hybrid Fontan patients. So we have several lines that we are following. So it's interesting. What moves us forward and what makes us, it's really fun.
Yeah, it sounds really exciting. I'm looking forward to see the new results. When you have it, please let me know. And
Of course.
I appreciate your time here. It was amazing. I don't know if you have any final words.
No, just simply, I'm very thankful for the invitation, and I invite you all to, if you have an idea, while taking a shower or whenever, write it down. Write it down in a piece of paper and leave it there, and try to come to that same idea, and try to make, if you think that is a very good idea, try to follow it and try to make it real, because we all have amazing ideas every day, but the ideas that become real are those that have a lot of work, those million minutes of work, and it's very, 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 very nice to make an idea real. So follow them. Go ahead.
Okay, really good. So thank you very much, Ignacio.
Thank you very much. Happy to see you.